Good evening, everyone. Thank you for joining us tonight. Welcome to the Evexia webinar series. Our topic for tonight's special webinar is Harness the Potential of Urinary Hormone and Metabolite, HuMAP, Testing for Comprehensive Patient Care. My name is Joanne Iverson. I'm the Director of Client Relations for Evexia Diagnostics and will be your host for this evening. Tonight, I have the distinct pleasure of being joined by an exciting guest, Dr. Ruth Hobson, who will be our presenter for this webinar. Ruth Hobson is a practicing naturopathic physician and doctor in the Clinical Education Department at Doctors Data, Inc. She received her Bachelor of Arts from Brevard College in Health Science Studies with a minor in biology and chemistry. Before we begin, just a bit of housekeeping. We encourage participation. So if you have a question, you may submit your questions in the questions field in the right-hand area of the interface. We will answer submitted questions towards the end of the presentation. If your questions are not answered this evening, you will surely receive an answer by email within the next day or two. In addition, you have the ability to download the slides to follow along with Dr. Hobson's presentation by clicking the download button in the handouts section of the webinar interface. Without further delay, I will now turn the webinar over to Dr. Hobson.
Thank you so much. I'm grateful for people who are here and live and those that are watching in the recording. This webinar is intended to increase your understanding of urinary hormone and metabolite testing. And that's going to include who to test, how to test, but most importantly, how should we interpret this HuMAP to maximize our patient results. So whether you're new to urinary hormone testing or you've been testing in this medium for years, I'm sure that you're going to find something from this presentation that's going to be helpful. So here is the hormone and urinary metabolite assessment profile. What we find is this allows practitioners to not only understand endogenous hormone secretion, but also hormone supplementation utilization, enzyme activity, hormone metabolism patterns, and even oxidative stress. So honestly, this is a very simple test, non-invasive, requiring only 4 to 5 urinary samples collected throughout the day. And with the addition of a liquid chromatography double mass spec, you're going to be able to see really sensitive and specific hormone measurements. So we're able to measure things that other labs may or may not be able to give us here. When we think about urinary testing, just want to make sure everybody's on the same page. Here we'll be talking about unconjugated hormones. And those are going to be hormones that we typically think about for sex hormones like progesterone, testosterone, estradiol. And then we'll also talk about conjugated metabolites. Those are hormones that have been modified by the body to become more water soluble. And we'll typically see that those are then excreted into either urine or the stool. Now, those conjugated metabolites actually have function within the body. Many of them do. And so we'll also look at some of the role as we move forward. Now, what I find interesting about urinary testing that it's very individualized for patients. So kind of like this fingerprint that you see here, we can learn a lot about a patient's health via how their hormones are metabolized. I've listed a number of conditions here that you can think about as far as testing. Now, in my practice, I see PCOS. I'm also looking at breast health for patients who have a personal or maybe a family history of hormone-sensitive cancers. You can even see in males, urinary complaints, hypogonadism, and so on. So I find that this test is very versatile in my patient population is who I can utilize it for. Now, the main advantages of our test, and I would say maybe in comparison to some other labs that you can find out there, is that we have a liquid urine collection. And that's going to enhance sensitivity, especially for those low concentration hormones and or metabolites. Now, when we think about comparison to other forms like a dried urine, for example, that has to be reconstituted from filter paper once the sample arrives back at a lab. And this reconstitution can lead to some of the loss of those polar steroid molecules and or creatinine for patient samples. And we also find with our collection, we don't have to restrict water, and so patients have an easier time just going about their day. It's really easy to pop them in after completion. We'll pop in the freezer for about 4 to 6 hours. They can be shipped right away, and the turnaround time is typically about a week. So I enjoy the advantages of a liquid collection also because you can add additional testing to that, and think about neurotransmitters or amino acids. I'm not going to harp too much on collection and how to collect. I just wanted to make sure that at least we're showing you some directions here and that patients are carefully reading. There's a preparation section here. We need to make sure that our cycling women are collecting at the right times, and there's going to be some information here. And then if we're also adding any testing on, again, I alluded to neurotransmitters or amino acid testing, there are some foods to avoid, and those are going to be within the preparation section that you see on your screen here. Again, collection is going to be those 4 samples and or 5. We do have a dinner time sample, a bedtime sample, a sample if you get up over the night, and then 1 upon waking, and then 2 hours post waking, and then into the freezer you'll go. Now, also, if patients have this is a really easy thing for them to refer to, but we have a QR code on the front, so they can just snap this. You'll see a handout. It'll give them all the ways in which they can test, pretty much answer any question that they might have, and it keeps them from contacting you and asking you for more information. We will see some of this handout here. I'm going to go through real quick just so you have an idea of what could be on here. Now, this testing is appropriate for males and females, both pre and postmenopausal women. And I will say, really, this test is designed for individuals 12 years old and greater. So if someone is younger than that, I would refer to other testing mediums. But for cycling women, we really want to catch that luteal surge. So here's some ways in which you could collect that. I wanted to also hit some frequently asked questions in this section before we really dive in. I often will have providers ask, what's the best medium for monitoring those supplemented hormones? And the recommendation for monitoring response to hormone therapy, typically I find is saliva, and this is due to the ability to discern tissue levels. However, when we want to think about urinary testing, this is the only medium that I can see how this supplemented hormone is moving through the body. How is it metabolized? How are we detoxifying? And I'll show you some examples of why it might be a little harder if you wanted to utilize this testing for levels. And that's because once we supplement, if we were using oral forms, we tend to see that those are going to go through two passes, right? So we're going to have more conjugated hormones turning into metabolites. So we have an overestimation of what is there. And topical delivery, that's going to reflect more of an underestimation, as we aren't really going through that, pass through the liver here. I will say that in addition to some other delivery forms, vaginal hormones, at least for this testing, I would say not really recommended, as it can contaminate, but if you wanted to, you could avoid that for about 72 hours before testing, and you could test on those. Now, sublingual hormones, when we're testing a patient on sublingual hormones, this is difficult because similar to oral, we are inevitably going to swallow some of that hormone, and so it can raise a little bit more of those metabolites. And so here we see, and we want to see a dosage interval or a holding of that supplementation when we're going to test for about 72 hours. And then when we think about pellets, this might be the one that, I'm kind of, yes, potentially we could see if this is the correct dosage, and that, you want to test mid-cycle, but it's the steady state of hormones that are here that are released over time. So I think you might be able to actually collect in this method. When we are thinking about utilizing, we'll say unconjugated hormones, I would say urine really isn't the best place to identify tissue levels, right? Again, but the only way that we can see how those prescriptions might be moving through, and the only place that we can see what's happening is impact of 2, 4, and 16-OH of our estrogens. It's a prime example of why you might want to, test someone even when they're on a script. But I typically am not using it to guide dosing, but you are free to do whatever you would like. And I will also point out that patients that are on things like glucocorticoids, let's remember that those can impact our testing. We'll pick them up in the testing. And so we typically will recommend individuals will hold those for about 4 to 5 days before testing. Now, I don't want to confuse everyone. You could definitely test your patients on hormonal therapy. And in fact, you're going to get a lot of peri and postmenopausal females that are already coming to you on hormones. And so, we want you to test, just guiding, is this the right dosage? I don't think this is the right medium. However, if you want to see how it's moving through, again, you can test individuals on hormones. And at Doctors, Doctors, they will have a printout for you here, and you will see that this little white triangle is used to plot your patient values. This is the postmenopausal female in relation to a premenopausal reference range. So this would be, where would your postmenopausal female fall on the premenopausal range? Now, this isn't exactly that we need to take all of our postmenopausal females to the premenopausal range. It's just giving you an idea of where they would fall. And so that can also help, guide treatment. Or is this kind of a safe dose? Are we being healthy? How are things metabolizing? Are the metabolites healthy? That's kind of a way that we can go about that. But let's look at the report itself. And we can see here, this is the first page of the HuMAP. Don't get overwhelmed. I know it is a little busy, but I think once I break this down for you, you're going to find that this test actually has a lot on, at least on the first 2 pages. It's actually designed to be a time saver for really busy practitioners. And so, if you had a busy clinic day like I had today, and you maybe had 10 minutes in between and you needed to review a case, these first 2 pages are going to be the meat of the test, and it's going to allow you to kind of zero in maybe on the internal aspects of the test that you need to review closer. So let's take a little tour. First, we'll see on the left-hand side of the page this half moon or ellipse that you see here. Notice that it is color-coded with the low or below reference range being that dark blue, and the above reference interval being that red color. And then we also have the optimal range is green. And now look at the light blue that is within the reference interval. It's just the bottom 10%. And we also have the yellow, which is relatively it's in the reference range. It's just the top 10%. So we're calling that out for you, making it a little more, helpful for functional medicine, as maybe warning signs that we're approaching levels that may be outside of the reference interval. Now, there are 15 analytes on here. I'm not going to read them for you. I don't want to take up our time in that way. But these 15 analytes will always stay the same. And it's going to change just based on your patient's information. And so you'll see the difference between patient 1, 2, and 3 here, and the dynamic shift that you'll see within that first page. Again, we'll talk a little bit more clinically, we'll dive into it, but this will give you right off the bat if you have any areas that you need to really pay attention to. The other section that I love is this estrogen section from the summary page, and it's going to highlight several things here: the 2, 4, and 16-OHE1 metabolites, and also how they are methylated. This is amazing quick reference. Let's focus on here. You can see some methylation activity. Just for example, in red at the bottom, you see that you have a high methylation activity. Now, this could be good in abundance. We see some of the more harmful metabolites, which we'll talk about, but the forward pathway is actually high methylation. And for some individuals, we know that they are methylating. I think that's a positive finding. The other things we'll see here is the percentage of 2, 4, and 16-OH in relationship to each other. And note here we have 4 is a little bit below the reference interval, or that dotted line. So the way that we would read this is we have, two areas of the dotted line, and you can see that that's the whole reference range. And then we also have the darker gray, and that's going to be the optimal range. Now, in this example that I've forwarded to you here, note that we have a lot of 4-OH metabolites and we aren't methylating. So this is going to be one of those instances where we're going to want to pay close attention to this 4-OH pathway. This would clue you in as a practitioner. I need to dig deeper into the estrogen section and really figure out what we have going on in this area. There are two other areas where we can find methylation, so not just for 4-methyl or 2-methyl E1, and we also have E2, and so that will be in the report. So this would clue you in that you can dig a little bit deeper. And here, just giving you an idea, we can also see 2-OH, which is that more healthy estrogen metabolite outside of the range. The only thing that concerns me here with the report like this is just that we're not methylating. So again, these are things that would alert you to, let's look deeper, let's flip to the estrogen section. We really have things going on here. The other section to pay attention to on the first page is the corticoid section. So this is going to give you an overview of cortisol and cortisone. Now this little dial here is looking at what is happening with 11-beta HSD activity. Is the body choosing to favor getting rid of cortisol, or is it choosing to store it as cortisone, or are we pulling it out of storage and returning it more into cortisol? And the other image here is just the cortisol and cortisone graphs together. I like to appreciate the patterning, that we see a nice curve, and then we can look deeper in. So this would be someone that I would say is a little bit more concerning. Cortisol being the major factor here. We see that the diagram is going to alert us to some, we have some upper range and or elevations here. This is going to be indicative of maybe inflammation. I see this in some of my insulin resistant patients and PCOS. So this tells me I need to look a little bit closer at the corticoid section itself. And lastly, on the first page, you're going to see key relationship section. So this section is 5-alpha reductase activity, aromatase activity, and again, methylation activity or COMT. And these are little sliders. So the way that they work is as you move to the periphery, so one side versus the other, this is going to show you the preference. Now, as you get closer to the middle, less preference. I will point out here, slam dunk, look all the way at the bottom. COMT methylation activity is swung all the way over to methylestrone, and that's going to favor that methoxy metabolite, which is actually a good thing. But that's just to give you a little idea. This is when you can say, oh, I do have a higher preference for one side versus the other. Now, the report is going to be divided into several neighborhoods, and this is what I think about when I see their test. And we have these different sections, and this is page 2 coming up, and this will be also dynamic for your patients' results. You'll see it's divided in a progesterone neighborhood, corticoid neighborhood, androgen neighborhood, and the estrogen neighborhood. And just really quick with that color coding, you can see how it would draw your eye to exactly where you need to look. So again, the first 2 pages are really helpful in that way. Now, this is an example of the dynamic nature, and so you can get an idea of what I was talking about as far as looking with quick reference. So patient 1, you see a lot of green, not a lot of areas to look at. Patient 2, mostly blue. That red area just really pop out at you. And then patient 3 in the estrogen section, that's all I can see is those big reds. Now you might have to get your reading glasses out a little bit to see this, but the more you see the color coding and the more you see this test, the easier the first 2 pages are going to be for you to utilize them as the quick reference. Now I will say, let's think about this test and let's take a step back and look at the big picture. So I'm typically counseling my patients as well as other physicians that let's not get fixated on correcting every analyte. It's not our responsibility or a patient's responsibility to move everything into the green or the optimal range. Rather, we want to kind of look at the whole pattern. So I typically think about this test like I would a river. So are things flowing? And if you compare the levels of analytes before and after an enzyme, this can give you a little bit of idea about enzyme activity. And so, if it's slow, is this like a dam, in the river? Or if it's moving faster, is this more like a waterfall? I tend to think about, excess deficiency in hormones and correlate that with our patient's clinical symptoms. So let's walk through these neighborhoods, and I think that's going to spark probably some questions for you guys, and I will also give you some clinical pearls as they come up. So the first neighborhood that we're going to look at is the progesterone neighborhood. You'll see we can actually measure progesterone. Most labs can't. I will say this is interesting in my clinical practice. Some labs look at alpha and beta metabolites, pregnenolone, and they will make that estimation for progesterone. That doesn't always add up, or not at least what I see within my patient population. So that's nice. And then allopregnanolone, one of my favorite to look at here. And in fact, we'll think about it in this next slide. So allopregnanolone, I love it because it crosses the blood-brain barrier and it binds to this GABA receptor. And it's really nice, helps people feel calm. Patients get really good sleep when you're prescribing it. If you're taking the oral formulation, remember, this is a concept from earlier, but we talked about how you might see overestimation of metabolites. And here you can see that here. But I like utilizing allopregnanolone on this test to see if it's low or if it's deficient. Could I add a little bit of progesterone oral to my prescription? Could this, help a patient who maybe is a little bit anxious and needs some sleep? There's always the right patient for that, but I will utilize that to say, are we moving in a pathway that would allow for allopregnanolone to increase? And then once you are on a medication, just remembering that we need to give some time. We need to wait about 72 hours, and then we can see how it's moving through. This is interesting. This is going to be a supplementation with an oral progesterone, and you can see progesterone level here and its metabolites overestimated. And then as we're utilizing transdermal, you're going to see that is a little less of the case. Now, when I get these reports, because I'm testing patients on hormones, what I'm able to see is while we have progesterone level that is elevated, this happens to be a 75-year-old postmenopausal female. So, her progesterone level is elevated because she's taking it. So it's not a worry to me. And I can also see that in the transdermal fashion, we are getting some allopregnanolone benefit. And it is in the upper range, but it's not too high. Now, within the progesterone section, I think it's important to talk about progestins and oral contraceptives in general. I typically hear, what do we think about that in urinary testing? Well, the mechanism of action of a oral contraceptive is to suppress FSH and LH, and that's going to decrease estrogen, preventing ovulation. You're also going to see that that's going to lead to a decreased production of progesterone. And occasionally, and you'll see this on testing as well, oral contraceptives can also increase cortisol binding globulin. So you might see the decreased total of cortisol concentration as well in the metabolites. And I would say that's for combination oral contraceptives. Progestin only tends to have less of an effect on cortisol levels within the plasma and saliva. This has really not been studied in urine, but it's probably similar. So knowing that most people want to know if it's okay to test, their patients on oral contraceptives. And for me clinically, unless I am wanting to show a patient what their hormones are doing, I don't really test patients on oral contraceptives because I know what I'm going to find. But if that information is helpful for your patient, if you want to switch birth control methods, if you think that's the crux or the obstacle to cure, feel free to do that. Here's a difference that we have found here. This is someone on a combination oral E2 and progestin. You'll see the top says 23-year-old female. And note that, again, estrogen and progesterone low as compared to someone who's on a progestin IUD. And you'll see here, some women actually ovulate on an IUD. You'll see progesterone levels aren't always very low, which is an interesting finding, but just note that those oral contraceptives really drive hormones down. So we kind of know what we're going to see. I don't know if there's clinical utility in that. When we think about the corticoid section, corticoid neighborhood, there are 3 areas I pay attention to the most, and that's going to be cortisol versus cortisone Again, that's that 11 beta HSD activity, metabolized cortisol, and then the cortisol versus cortisone metabolites. That one's different. Okay, so let's look at this cortisol versus cortisone. So because we're looking at the influence of the kidney, we aren't necessarily seeing within urinary testing, at least, the HPA axis directly. Rather, we're seeing the body's response to cortisol. So it's kind of a different way to look at it. I think of it more as like a broad strokes, what's happening overall in the body. And this, enzyme is particularly active within the liver and or kidney, depending on where we are looking. And things that can enhance this would be things like inflammation, obesity, metabolic syndrome, even thyroid function. And then the other area of the test we would want to look at would be metabolized cortisol. So metabolized cortisol is a measure of what the body has utilized. And this is actually metabolites of cortisol and cortisone. Now, when we think about high levels, we'll think about increased cortisol clearance. Either that's overproduction, things like obesity and inflammation, you're going to see affect enzyme activity and metabolism in different ways. But hyperthyroidism, that's going to be one that you can see with high metabolized cortisol. When we have a low metabolized cortisol, think about that as a decreased cortisol clearance. Again, inflammation and obesity will play a factor here for different reasons. And then you'll also see that hypothyroidism can come into play. And that's just some examples of what you might see there. So again, the metabolized cortisol is giving you a better idea of overall what the body has utilized. And then when we're looking at metabolites of cortisol and metabolites of cortisone and their relationship to each other, this is gonna give you an idea of the body's preference. So we have a more preference for cortisol. Do we have a more preference for cortisone? Let me show you some patterns, and these are some of my patient cases, and I didn't have time to kind of snip and go through all of them, but I thought I'd give you just little snippets of things that I found clinically. Here's the metabolized cortisol. You'll see that that's low range. This happens to be just an underweight patient, and having a patient that's underweight, you can also see that decreased cortisol clearance. The bottom left-hand side with hypothyroidism, this can definitely slow a cortisol clearance, and also is going to give you some decreased cortisol metabolites as a result. So you can see that as well. We look at the top right. This is that similar to what we saw before, that cortisol versus cortisone, what's happening with that 11 beta HSD activity. And here we see it's cranked way up. This happens to be a patient of mine that we're working on some lifestyle things, and she's a BMI of about 28 or 29, I believe. We see that 11 beta HSD1 activity. We have this big preference for cortisol, and in fact, cortisol for the day is also elevated. And then the lower right-hand side, a case of hypothyroidism, which can upregulate liver clearance of cortisol. And so you see when you have increased levels of cortisol, typically will also lead to cortisone and then higher metabolites. So you can pick up a plethora of information just by looking through here. Now, just for your information, most of us as practitioners are trying to figure out how we can kind of downregulate that 11 beta HSD1 activity. So how do we turn, down the cortisol? And that's going to be doing things like reducing inflammation and addressing insulin resistance, central adiposity, and also physical activity. But here's some other things you can think about as far as bitter melon, holy basil, curcumin, and you can see how that's targeting inflammation, insulin resistance, and those types of things as well. I will also say within this neighborhood, doing adaptogenic herbs and those types of things that we typically will think of for HPA axis can also be very helpful. And then the androgen neighborhood, this is a large neighborhood. I love to appreciate this as a pathway, as a flow, as a river, what's happening. We have so many things we're gonna touch on here. These are, DHEA, DHEAS, we're gonna see aromatase, 5-alpha reductase. We're going to see if we have a preference for 5-alpha. We're going to be able to move through this pathway with ease here. And then I will say we'll also look first at aromatase. So aromatase is an interesting enzyme. So it converts androstenedione to estrone and testosterone to estradiol, active mainly in the adipose tissue. And I will say can be active in both male and female cases. It's one to pay attention to. You're going to see that aromatase activity, remember, is on the first page. So it'll be the only place that you'll be able to kind of see this within the HuMAP. I pulled a case here. This is just someone with metabolic syndrome, having trouble losing weight, and elucidated the fact that this individual actually had more estrone. Some of his androstenedione was pulling towards his estrone. And so it gave me some clinically actionable steps that I could take to help him lose a little bit of weight, and as we started to address metabolic syndrome. And I'll say the activation of aromatase enzyme here is going to be, basically just how we're living in the world, right? Stress, xenoestrogens, poor dietary choices, and so on, high insulin, inflammatory cytokines. And most of the time, I'm typically dealing with how do we down-regulate aromatase. So here I've pulled together a pretty extensive list for you. These are ways that you can think about down-regulating aromatase activity. Doing things that like zinc or chrysin, I would say Damiana comes to mind right away, nettles, those things, but also things that would decrease inflammation. So that's why you're going to see some of those breast cancer treatment drugs that are made the list here as well. Speaking of breast cancer, I will say that we're going to talk a little bit about, I think most people kind of pin estrogens with that, and we'll talk a little bit about that. But I also wanted to make you aware that at least when we're talking about within the research has shown that having higher levels of testosterone can lead to certain types of cancers. And here we're looking at breast cancer specifically, but that it's actually not the testosterone that leads to this cancer, right? It's the aromatization of testosterone that increases the proliferative effects of estrogen. And so, that enzyme is really important to look at in female and male cases for breast health. Also, when we think about male health, we want to look at too much aromatase activity increases estrogen levels, leading to things like an impact on erectile function and libido and sperm production. So those are areas that we would want to examine further. 5-alpha reductase is another enzyme within the androgen neighborhood that we should be looking out for. I will say that 5-alpha DHT tends to be more androgenic and potentially causing more symptoms for patients. And I think typically for females, we'll see things like acne and scalp hair loss, mood instability. And then in males, we have this excessive activity. Typically think about maybe more prostate concerns, also scalp hair loss. Now, when we want to, again, we can look at metabolism here. We can decide, do we have more alpha? Are we favoring more alpha? Are we favoring more beta pathways? You can see that here there are two pathways that we're going to look at. It's androsterone and eticalanolone. And then you can also look at their alpha and beta metabolites there as well. I want to point out that while we want to treat most of the time and downregulate if we can, a 5-alpha reductase, if it's an issue, it does impact other areas within hormone cascade. So this could potentially also impact areas in the cortisol section, as well as in the progesterone section, especially when we're thinking about going more towards that allopregnanolone. Now, I'm not saying don't treat it if you find it. I'm just saying maybe this is a temporary treatment. Maybe we're really watching this and looking at other pathways and seeing how it's impacted. We're not this linear system. We are very connected. I would think about most of the natural 5-alpha reductase inhibitors here, like saw palmetto. You can find berberine, nettles. Those are pretty well ubiquitous within the supplement world there. I want to show you a case example of a female patient. This is a female patient with PCOS. And again, when you have a PCOS patient, it's not that, slam dunk, I didn't diagnose from this. But what I have been able to do with PCOS patients is I can follow the metabolites, which is very new to me. I can see how our supplementation is working or not working. Are we able to downregulate some of this 5-alpha reductase activity? So I think this has been very helpful. You know, PCOS is, again, very common among menstruating females, and I think this is a wonderful way to just see if our treatments are working. And patients like to see that their hard work is paying off as well. And here we have a male patient, and this is a patient case I just wanted to bring to your attention. But this is a male on high-dose topical testosterone using a whopping dose of 100 milligrams a day. That's way more than I intend for my patients to have for sure. But as you can see, all of his pathways were lit up. He did not feel very well. In fact, this is topical, and his dosage interval was 72 hours. And so remember how I said that topical underestimates metabolites. And so these were typically higher. And then also, this is a patient you would want to think about too. Are we aromatizing any of our testosterone? If I'm giving a male patient testosterone, I want to see, you know, are we going more towards 5-alpha DHT? Are we more alpha? And I want to see, are we aromatizing any of that into estrogens? And that's been very effective in my clinical practice as well. Okay, and this is the estrogen neighborhood. Probably my favorite section of this test. I love it so much. I think there's a lot we can learn from it. We have a lot of clinically actionable steps we're going to think about. Particularly, we'll talk a little smidge about aromatase because that's going to come up, but I've beat that to death, I know. And we're going to talk about phase 1 and phase 2 metabolism, COMT, and then ways that we can think about kind of following our endogenous or our BHRT exogenous hormone prescriptions here. So I'm going to skip through aromatase, but I'll leave it in the slide deck so you'll have it. This case example here, aromatase, at least the image that I've chosen here, this is not really active here. You'll see it's all the way to the left-hand side of the screen, so aromatase activity is low, so we're not seeing a lot of activity happening. Okay, so phase 1 detox. Now this is important. Phase 1 detox does way more than just estrogens. We see that this is going to take things and make more water-soluble compounds. Phase 1 is going to also, besides estrogens, transform our antibiotics or certain pharmaceuticals and xenobiotics out of our body. Now, I will say that phase 1 does cause some intermediary metabolites that can need some additional help for phase 2, right? So reactive oxygen species are happening here. And then, you know, if we're not taking care of those, we can kind of think in our mind that we're moving forward to DNA damage. So let's talk about these phase 1 intermediary metabolites. We're going to call them the catechol estrogens, or these are the conjugated estrogens. You might also know them as the hydroxyestrogens. It depends on what you're looking for in the literature here, but we have 3. So 2, 4, and 16-OH. E1, so estrone, and E2. Now, 2-OH, E1, and E2 considered safer estrogen. They're non-proliferative. That enzyme that we're going to pay attention to is going to be CYP1A1. Don't worry, we're going to talk about that in detail. And then 4-OH, E1, and E2, this tends to be more DNA damage potential. The ways that we'll talk about this is going to be how is it upregulated or downregulated by CYP1B1, and 16-OH also has some DNA damage potential. It kind of lives in a gray area, less so. It's not as estrogenic as the 4-OH, but it does have some estrogen potential. So proliferation is what I mean by that. Now, we will look for CYP1A1. And this is going to be, again, a healthier pathway. I would say a lot of harmful environmental toxins are also metabolized through CYP1A1. And then remember, even though this is a healthier pathway, it is an intermediary metabolite. So we want to make sure that at least we're methylating that. We'll talk about that next. But this is the enzyme that we're going to want to typically think about. How do we upregulate that? That would be things like DIM, coffee, rosemary, resveratrol. I3C, those are the things that immediately come to mind. I would say DIM is probably ubiquitous within the supplement company world when we're thinking about estrogen metabolism. And one thing that's pretty interesting to follow, if I'll kind of refer back to an image, but our bar graph that we have here, so the expected ranges for 2, 4, and 16 OH, and you'll see that you can follow, is DIM working if we have 4 is more elevated, and we needed to bolster the 2 pathway. You know, we want to see those bar graphs change. So in this patient case, you know, DIM is working. We have a little bit more as far as our 2OH, so we're creating more of that safer pathway. Now, when we want to think about CYP1A1, it can be maddening because you'll see that some of the treatments, the first little bits of treatments are going to be, or that we have listed here, or things that are kind of out in the world and we consider harmful. And the rest are going to be things that you may have patients on already. And that, you know, think about green tea or sulforaphane and broccoli, St. John's wort, those kinds of things. And that's going to potentially downregulate CYP1A1. Now, I'm not saying don't use them. What I am saying is if you know you have something that's on this list and a patient is utilizing and you get a report back and you need to upregulate it, just bump up some of our, you know, DIM, for example. Bump up the things that are inducers as far as this enzyme goes. Okay, so we talked about the safer one. Let's talk about the more harmful one. So this is the 4OH pathway. So CYP1B1 will push estrone to 4OHE1 and estradiol 4OHE2. This is more readily found in tumor tissue compared to normal tissue, and you know, potential for carcinogenesis here. And I would say, in addition to cancer, there is also research in CYP1B1 being increasing, fat intake, uptake, and it's associated with metabolic syndrome. So this is one that when I see it elevated, when I see it upper range, I'm definitely treating it. You know, if nothing else for carcinogenic potential, but also we want to think about, you know, do I want to store more fat? Am I in a metabolic syndrome cycle? And you'll see that in your patients. You'll see that pop up for them. So here we have an instance for prostate cancer. We're typically talking about, I think all the time we talk about estrogens and estrogen metabolism for breast health, but here, you know, CYP1B1 expression is increased in prostate cancer. So those are things that let's not forget our male patients when we are looking at this test as well. Typically, we want to downregulate this, and this is going to come from anything in the Apiaceae family, resveratrol, quercetin. All of this is going to be helpful. And then when we think about what potentially might upregulate, some things on this list you're going to also want to avoid. This is going to be things like diesel exhaust, right, or harmful UV exposure, leptin resistance, inflammation, and insulin resistance will also all upregulate that. So treating those, you know, removing the obstacle to cure is going to be helpful when we are trying to get these more healthy metabolites going. The next enzyme to think of in this you know, family of 3 here is 16-OHE1. So CYP3A4 is the enzyme that creates this metabolite. And I will say this is probably the hardest one to manipulate because it's also metabolizes about half of the drugs on the market. So if you have a patient population with polypharmacy, this is going to be one that you maybe are a little bit more careful about. Maybe it's the exact right person that you're trying to modulate this for. But I will, you know, say that this enzyme is really important and helps detoxify bile acids. It partially degrades our vitamin D, and we really, really need it. Sometimes I'll encourage patients to upregulate this enzyme. Please note that you might have to look at medications and see if you're going to be changing clearance and those types of things. St. John's wort, valerian, ginkgo, those things have research here. And I will say it's pretty interesting that women, or at least females, and tobacco smokers and diabetics, they all tend to have higher CYP3A4 activity, for what it's worth. It's a really interesting factoid I just threw at you. when we want to downregulate this, and I would say many polyphenols can be used here, phenolic compounds, tannin, sulforaphane, ginseng. Those are all can impact and downregulate the system. And again, and I'll say you're going to find that natural products are going to come up on these inducers or depressors of enzyme activity. And that's because, again, our body is not linear. We need to upregulate and downregulate as the body sees fit. And so here's just things to be aware of if your patient is on this, maybe coming to you, and or if you want to augment their supplements here. Now, let's think about phase 2 detoxification. So the whole thing that phase 2 is going to do is further break down these toxins into more water-soluble products, and it's going to reduce the toxicity of those phase 1 products. So once we typically are moving into phase 2, once we have phase 2 metabolites, let's think about this for 2,4-OH. These intermediates can potentially be converted to quinones and semiquinones. And if you don't know what those are, they're just, think about them as reactive oxygen species that can cause DNA damage. Now, if everything goes to plan, these metabolites are detoxified via methylation, and that's going to render them inactive, and they're able to pass from the body. So essentially, when we think about estrogen metabolism in general, we're thinking about, are we oxidating or are we methylating? And methylation, again, it's going to inactivate those catechol-estrogens that we talked about before, or those more of those conjugated estrogens. It's going to increase solubility, and then we're going to have more excretion there. They're stable. They can leave the body. They're not causing harm or damage. The other side, if we have oxidation, this is when we can have some peroxidase enzymes kind of moving into quinone and semiquinone formation. And then the body does have other systems to make sure we can keep this in check. But we don't want these because this is what causes DNA damage, carcinogenic potential, if you want to read through lines there. On the HuMAP test, there are 4 areas where we can look at methylation activity, COMT activity. It's going to involve ratios of these metabolites. And you'll see here we have 2-methyl-E1 to 2-OH. So we have the estrone metabolites, 2 and 4. We have the estradiol metabolites, 2 and 4. In this case example, they don't match up across the board. And I see that all the time. In fact, for this patient example case, we'll look at 2-methyl-E2 and 4-methyl-E2. So it looks like the estradiol side of estrogen metabolism, at least in both 2 and the 4, is a little slower. And so this is a case where I would think about increasing things for methylation and possibly also doing other things to decrease amounts potentially of 4, depending on what the other parts of the test looks like, to see if we can slow that down a little bit so we're not overrunning the system. Now, here we'll see, I wanted to just bring out the fact that there are 3 main ways to decrease the potential that the 4-hydroxyestrogens form those DNA adducts. So we talked about how you can downregulate 1V1, you can support methylation and COMT activity, or you can also support the glutathione and sulfur transferases. And that's going to be helpful here. So here's some strategic ways that we can go about this. For methylation support, we're going to think about foods, cofactors, methyl donors. They're all listed here. You'll have these slides. And then for phase 2, we want to think about, again, we'll continue to downregulate or decrease our high sucrose diet. So again, dietary and lifestyle choices are going to be huge when we think about methylation. Addressing leptin resistance. This is all the things that we're doing in functional medicine. What I love about this test and having this testing is it goes so well with what I'm trying to get my patients to do naturally anyway. Some other things to note that can affect methylation. Think about our PPIs and our antibiotics. You'll see that. And I would say those 2 prescriptions right there are across the board in most patients. And so, you know, we already have a strike. We can do a lot as integrative medicine practitioners. The total summary of phase 2 I've listed here. And remember that we are going to move through thinking about how we can support these 4 areas. You know, we talked about CUMT. We can also give some things for methyl donors, methylfolate, for example, and then, you know, thinking about possibly DIM, and then also supporting those glutathione transferases. I like things like curcumin, resveratrol. Those are things that will come up. So there's the summary slide when you need it. Now, I touched a little bit about estrogen quinones a little bit, and here's some research on estrogen quinones and breast cancer. What we find is that we have an increased amount of estrogen DNA adducts are found in not only people with several different types of cancer, but also in women at higher risk for cancer. So it's indicating that the formation of these adducts is on the way to cancer initiation. That's why it's very important that we're, you know, taking this seriously, especially in the population that maybe has breast health concerns, family history, that kind of thing. I will say that there are 2 substances, at least very well researched for quinone reduction, NAC and resveratrol. Both of them work very similarly. I will say resveratrol one-ups NAC in the fact that it can also modulate that CYP1B1 enzyme. So it's going to actually reduce its activity and potentially the less 4-OH-E1 and E2 to begin with. But these can be very helpful in decreasing those adducts here. Now, we've kind of moved through phase 1 and phase 2, and one thing that I would say most people forget about is phase 3, and phase 3 is just elimination from the body. So honestly, if your patients are not pooping, they're not excreting, we're not getting rid of, they're gonna have issues. And you know, typically, I'll talk to patients about, you know, the possibility of, you know, needing to bring on other supplements if we're not eliminating daily, you know, is very important to me. And in the back of my mind, I'm thinking about beta-glucuronidase. It has an ability to recirculate estrogens. We see it kind of repackages them. It's increased, this enzyme is increased with low fruits and veggies, low fiber, high sugar, none of that standard American diet. And those are things that we can modify for sure. I also do stool testing, and I apologize, I just popped this over to give an example. This is a GI 360 from Doctor's Data, but you can also see beta-glucuronidase on this test as well. It gives you a lot of information about fiber and those kinds of things, but I like to see beta-glucuronidase and pairs well with this report. But that's definitely a consideration I have. I think gut health is something that honestly I would consider treating as first line before you do other things, because if we can get elimination on board, then we can move things throughout out of the body faster and more efficiently. So whether that's hydration and fiber, you know, maybe we need to increase some movement, magnesium, whatever your treatment pattern is for that. And additionally, you know, while we're getting the dietary things on board, if we have low fiber, if we, you know, our gut is producing more beta-glucuronidase, we can think about that calcium D-glucarate. It's going to kind of keep those estrogens from being reabsorbed within the gut. So that can be really helpful. The last section of this test is going to be 8-hydroxy-2-deoxyguanosine. And this is not an estrogen metabolite. It does pair really nicely with these metabolite information. But this is going to give you some information about active oxidative stress. So when we have injury to lipid cellular membranes, proteins, we can, in the mitochondria, we'll see that this is a byproduct. We can actually measure it. So when we see it elevated or even upper range, lets us know that we have some active oxidative stress happening. So I would say pairing that with estrogens, yes. Pairing that with, you know, things like maybe an activated or high cortisol states, if we have, you know, this and an elevated 8-hydroxy, or maybe we have lots of aromatase activity. You know, think about how you start to see the bigger picture here. Remember, like, pull yourself out and look broader in the picture. Most patients, I will say, have some form of inflammation, just whether the extent of inflammation we have. So here's a list of oxidative stress and disease states. And when we think about treatment for oxidative stress, it's always to find the root cause. Like what is the cause of this oxidative stress? And here's some supplements that we can kind of use to battle oxidative stress, but until we remove, it's like putting a little bit of trickle of water on a huge fire. Until we remove the source of the fire, the thing that's keeping it driving, sometimes these are Band-Aids. So really getting to the cause, but these are great for squelching and helping with a little bit of those fires throughout the body. Now, I will tell you that there has been a paper that came out and it was looking at estrogen, and it's titled Estrogen, the Necessary Evil for Human Health and Ways to Tame It. So that kind of caught my view here, and I will say that there's some nuance to hormones, right? We need all of them. They're all very important. Sometimes we vilify estrogens, and I don't want you to think that I'm doing that. It's the disproportionate amount of estrogens that we might have that can kind of lead to further health problems, such as breast and ovarian, prostate, thyroid cancers, and those kinds of things. And we'll think about that as well for PCOS and even PMS, endometriosis, what have you. We'll look at this. In fact, it can also come from other areas. So you're going to find in medicine that honestly, the truth is a little gray area when we think about estrogens. And to be completely honest, a lot of research is pointing towards, again, disproportionate amounts of estrogen, whether that's coming from the environment, whether that's inborn metabolism errors, beta-glucuronidase, aromatase. This research here is pointing to aromatase as being a driving factor for stimulation of cancer cells within the breast tissue itself. So we have to kind of look at a broader spectrum here as we're moving through and health for our patients. Now, here we're going to think of beyond the colors. I want you to also know that red does not always equal bad and blue does not always equal bad. There are some instances, for example, when 4OH might be low, that's a great thing. We don't have a lot of 4OH, great. The same thing for red, when red is a positive finding. Well, red, we have a lot of abundance of maybe our methyl metabolites. That can be great. Again, if we have a lot of methyl metabolites, we need to make sure we're eliminating. That can be a reason for these elevations here, but it's moving through, things are moving through the pathway. I want to remind everyone of the therapeutic order for treating. So we want to start kind of at these foundational things and move up the hierarchy as needed. Some more of the functional medicine approach. Also, there is a hormone and urinary metabolite clinical and therapeutic considerations treatment guide, and I wanted to make sure that everyone is aware of, and I'll show you where you can get that on the website, and I know that you can also find it here, and we'll drop it in the comments. Evexia will provide that for you as well. Great resource. It's going to give you a little snippet of what's happening in the pathways. So we'll look at the enzymes. This will give you a good overview and idea of how you can treat, what you can use, so you don't have to remember everything I was saying. I cheated and gave it to you at the end, so you had to pay attention a little bit here. And then also some quick reference tables that have the most utilized substances with enzymes, so you can see what is upregulating, which is the plus, and what might be downregulating, which is minus. So if you wanted to get it from Doctor's Data website, this is the location here. You would go under endocrinology in the testing menu, and therapeutic considerations, it would be right there. So as far as overview of treatment, when you are kind of thinking about things to focus on and getting really good at, these are the common treatment themes. So if we can get really good at downregulating aromatase, figuring out how to upregulate COMT, upregulate CYP1A1, and so forth, you're going to have a lot of success with patients in general, also just in seeing numbers change on this test. I would say the common treatment considerations are going to be those that we want to push within more of a holistic approach to medicine. And this is going to be, thinking about fruits and vegetables and fiber and moving our body, decreasing insulin resistance and some other, I would say, anti-inflammatories, major things like B6 and B12. Those are going to serve us well. I'll leave you with some pearls, or this is kind of what I think about when I am looking or trying to choose a test. For the HuMAP, remember that urinary testing is showing what the body has utilized or metabolized. So this is big picture. We don't have to have all the grains. Remember the river. What areas are causing more or less volume or flow. Choose this test if you want to understand endogenous hormone flow, enzyme activity, or if you want to track the movement of your hormone prescription. So how is it metabolizing? What is the addition of this hormone done to the body? We can also see that. It's extremely helpful for cases where hormones appear balanced on other testing methods, but sometimes patients will have symptoms. The HuMAP can also elucidate areas to further improve for that symptom management as well. I know I've given you a lot of information. I'm going to have time for questions if anybody has that. And let's see if we can maybe clear some things up for our audience.
Dr. Hobson, thank you. That was just some great information. I personally just like the layout of the neighborhoods and how you just dived into that. It just made it very visual. Folks, we have some time for questions. Again, that was a great presentation. We have just a few minutes. If there's any questions, feel free to go ahead and just type that in there. And then we'll go through the last couple slides with that. But just a reminder that, again, the slide presentation is here to download, as well as the clinical and therapies consideration right in that handout section. So I guess we'll just give it another minute for any questions and see.
They're going to let me off easy.
What we have. Again, a great presentation. If there is anything that comes up with it, I'm getting some good positive feedback that it was a great presentation. I know they will circle around with us and we'll reach you if there's anything with that. Let me give it 1 second here. Let me just see if I have anything in here with that. How are methylation rates in estrone versus estradiol different?
Yeah, that's interesting. And just the nature of working at Dr. Zeta and seeing hundreds of reports in the back end and in my own clinical experience, I do see that we will have methylation activity that's not across the board, all green, all blue, upper range, low range, that kind of thing. What I find sometimes is that either estrone or estradiol methylation is a little faster or slower. Why that is, I'm not sure, but I do know that the methylation of our estradiol metabolites, for example, are very important, and they actually have the same clinical implications as our estrone metabolites. The fact that you can look at them together and see that we're where those discrepancies are, we might have missed them if we're utilizing other testing that's not showing those estradiol metabolites. But why that happens, I'm not sure. I always think because we're not linear, but that's probably my simple, brain answering that question. But they are different. I see it all the time.
Thank you. Here's one more. I have someone that has a normal DHEA, but high DHEAs. What does that mean? Sorry about that. Maybe we'll have to circle around with that.
So normal DHEA with a high DHEA-S. So for that, I would say you're going to see that that person potentially is utilizing more of the storage form. So, DHEA is a prohormone, and that can give us access to more androgens or and then downstream estrogens as we need. So when we're choosing to store it, several reasons. Inflammation can be a big factor here. But is there a reason that maybe we have too much androgens, maybe we have androgen excess? Sometimes you'll see that will pop into the storage form as we start to heal. I see that in PCOS sometimes, where our DHEA will start to look normal, but our storage form is a little bit higher. And so, thinking about treatments, there's an enzyme called the SULT enzyme, and you can modulate that. Think about, in this case, maybe licorice would be something to consider. You can look at that pathway check out the handout as far as treatment guide goes, because that's going to be, it's going to give you so many options for if you need to pull it out. I would say really only clinically is it concerning to me if my DHEAS is maybe an upper range or elevated, if my androgens are low, if I'm really seeing that there's a deficit, so it's in the storage form and I need it to be in the more active form, that's really only clinically when I tend to think, I need to do something in this area.
Thank you. I'm going to ask you one other question, and then we'll just move along to the final end. Can you share what, if any, differences between HuMAP and the Dutch test?
Yeah, so I would say go back to just the advantages slide that I talked about, but I can give you a little bit of information, at least on the doctor's data side. So we did a lot of in-house testing, and we're trying to get the most reproducible samples we could. And that's why doctor's data ended up going with a liquid collection. So that's the big difference. We're not using strips, we're not drying, we're not restricting water. We have a liquid collection, really simple in a vial. You can add other testing to this. We're not reconstituting from paper strips, right? So we have this viable sample that we can add neurotransmitter testing from, you take neurotransmitter testing from, or amino acid testing from. So I think that's a big addition. Another thing is we have a little bit more sensitive instruments. We're able to measure things like progesterone, androsterone, as well as those methyl metabolites and hydroxy metabolites of E2. You'll see that that's a difference within the pathways. Allopregnanolone is also something that we can measure in addition.
Thank you. Can you, let's go ahead and just move to the next slide with that. Just a comment again, what a great webinar this is. Another one of our clinicians ready to order one next week. So thank you so much for that. Dr. Sedano is not on, he's on vacation, but again, for everybody here, you know, utilizing Ask the Doctor, any help with lab interpretation, questions on clinical conditions. Dr. Sedano, our Director of Clinical Support and Education, very familiar with this test. So again, any feedback and help as you are running these, you know, please reach out using Ask the Doctor. And let's just finalize the last couple things. So now that we've learned about urinary hormone testing and the value of HuMAP, I would like to review how to order the test before concluding the webinar. And everybody too, from the test menu, you can navigate right through doctor's data. You can click on this test. You're going to be able to download, print off exactly the sample report that Dr. Hobson has gone over and some of the clinical information on that. So you can find that right from your Evexia test menu. And then to really go through to place orders, you will log into your Evexia account. And that'll be on the left-hand side where you will register or create your patient or client that you're going to assign the test to. Then you will click on Specialty Labs and find the Doctor's Data Products tab, and then be able to locate and select the HuMAP test. Complete your order, and you'll be able to place orders. Orders can be assigned to patients or clients to pay Evexia directly, or we can bill the clinician as those results come back in. So both of those are available. And that's really it. It's just that simple. And I think our final slide will just come up. All the ways to reach us here at Evexia. We're here till 8 a.m. to 8 p.m. Eastern Standard Time, Monday through Friday. Live chat is available during those hours, and our toll-free number, 888-852-2723. And of course, we want to be able to support any of our practitioners and clinicians. So thank you so much. For any questions or issues, these are the ways that you can contact Evexia. Dr. Hobson, thank you so much for this informative presentation. A recording of this webinar will be available by email in the next few days. And if you didn't have a chance to download the handouts and the clinical therapeutic considerations, we will have that available for you as well. So thank you everybody for joining us for this webinar event. Until next time, from everyone at Evexia Diagnostics and Doctor's Data, stay healthy, stay safe, and we wish you all the best on your pathway to wellness. Thank you so much, Dr. Hobson. Good night, everyone.